This video mainly introduces arthroscopic tibial tubercle osteophyte debridement and gout crystal clearance for the treatment of osteoskeletal disease complicated with gout in patients with anterior knee pain. The orders and disclosures are as shown in the figure. X-ray, CT, and MRI are used to clarify the patient's condition. From the imaging pictures, we can see the tibial tubercle osteophyte and damaged tendon. Urate crystals cannot be detected through regular imaging examinations, so we opt for arthroscopic exploration. The first step is to locate the portal position. The surface positions of the lateral portal to the tibial tubercle and the medial portal to the tibial tubercle are about 2 cm beneath the joint space, and approximately 1.5 cm from the edge of the patellar tendon. The blue arrow points to the patellar location. The green arrow points to the edge of the patellar tendon location. The green arrow points to the joint space location. The red arrow points to the two portal locations. The second step is to explore the surgical field. Arthroscope enters through the lateral portal to the tibial tubercle, while the electric shaver enters through the medial portal to the tibial tubercle. Arthroscopic exploration reveals the find point above, the tibial tubercle osteophyte, the posterior side of the patellar tendon, and the proximal patellar tendon insertion. This enclosed area is referred to as the bursa. The third step is to clean the tibial tubercle osteophyte. Since the tibial tubercle osteophyte is a third-dimension structure, the shaver and the drill needs to clean it from the proximal to the distal end and from the front to the back, using forceps to take a small amount of the tibial tubercle osteophyte as a pathologic sample. The cleaning standard is that the protruding part of the tibial tubercle disappears and a slight depression remains. During this process, care must be taken to ensure that the cleaning reaches the proximal patellar tendon insertion. If it does, further cleaning should be stopped to avoid further damage to the patellar tendon insertion. The first step is to clean the calcified lesions on the posterior side of the patellar tendon and at the upper end of the proximal patellar tendon insertion. The shaver is first used to clean the calcification on the posterior side of the patellar tendon. Calcification often appears yellow, while healthy patellar tendon are white. During the debridement of the calcification, it is crucial to continuously pay attention not to damage the surrounding white areas. Once a normal patellar tendon tissue deep to the calcification is exposed, further debridement should not be continued. Following this, the calcified lesions on the upper surface of the junction between the patellar tendon and the tibial are cleaned by shaver, and a small amount of diseased patellar tendon and calcified material is taken as a pathologic sample. The fifth step is to clean the urate crystals. The shaver is used to clean the deposited urate crystals on the tibial bone bite from proximal to distal, ensuring a slight depression remains at the tibial tubercle. Next, the urate crystals deposited on the posterior side of the patellar tendon and on the proximal patellar tendon insertion are cleaned, taking care to preserve the patellar tendon tissue and avoid damage the insertion point. Finally, a sample of the urate crystals is taken for pathologic examination. The sixth step involves swapping the position of the arthroscope and shaver and repeating steps 3 to 5. At last, arthroscope exploration of the tibial bone bite and the patellar tendon confirms complete osteophyte removal and no tendon injury, followed by irrigation of the surgical area, wound closure and pressure dressing with sterile gauze and elastic bandage at the wound site. After completion of the surgery, the patient is transferred back to the ward. Table 1 introduces the advantages, disadvantages, and risks of the technology. Table 2 introduces the key points and the precautions of the technology.